There's a phrase out there. Is it a term of art? Unmanaged severe asthma? What does that mean to you as a payer?
I mean, clinically speaking, unmanaged is they're not, they're still continuing to have exacerbations and hospitalizations while on their control of medication.
See, I don't think that's a great term.
But that's a term that's out there,
Yeah,
right?
I know. Unmanaged means I can have a severe asthmatic that's doing great, okay? He's taking his inhaled steroid and LABA. You take it twice a day on one burst of steroids a year. I'm not worried.
Yeah, so we don't use the term unmanaged. We do use the term uncontrolled.
Uncontrolled is,
Okay.
or
Yeah.
difficult to control.
Yeah.
Those are the patients that
Yeah.
we really care about.
Do biologics, all the biologics require prior authorization?
Yes.
Yep.
Okay. And are patients required to follow a stepwise treatment plan prior to biologics, in your view?
Only in
We
the,
require that they have tried maximum tolerated controller medications prior to using. And again, the identification of a severe asthmatic by diagnosis, that's physician attestation, but we do require that stepwise approach. So I would say yes.
There's no insurance company today that doesn't require they have failed on a inhaled steroid LABA. Some require additional therapy, a leukotriene antagonist, a LAMA, long-acting muscarinic agent that have been approved for asthma.
But we don't say failed. We say they continue to have exacerbations
Yes.
that are uncontrolled, even on, and the assumption is they're compliant, but yes.
But you already said, he presented very good data that a lot of them aren't compliant. And the question there is,
Jeffries, a recent study shows scarily that well over 40% of these people hadn't been taking their ICS with regularity prior the year before.
and the question there is,
You can make the case for me to make it more difficult because I can
I'm
say
not
confirm.
suggesting,
No, no,
but part of the reason
Right.
is why are they not using it?
right, maybe it's because it doesn't work.
Correct.
I
And-
had a patient not long ago that says, I cannot, I mean, he's smart enough to say, every time I go to the pulmonologist, okay, I get a different inhaled steroid LABA. They all don't work. Don't give me another brand. I need something else.
What is the difference in mechanism of action in the current and the emerging biologics? Who wants to tackle
I'll
that?
do the current. So we've talked about them before. We have really three major classes. We have the anti-IgEs, that would be omalizumab. We have the anti-IL-5s, as Don said. Two of them are direct blockers. That would be reslizumab and mepolizumab. And then we have an indirect programmed cell death, so to speak, in the benralizumab. And then finally, that's all anti-IL-5. We move to IL-4 receptor alpha blockade, which blocks both IL-4 and IL-13, and that would be dupilumab. Now, what's interesting is when you look at all of their data, they're looking at largely the same population in all of the studies.
One thing you have to understand about these biologics, they don't alter the natural history of the disease as much as we know. They're not a true immune modulator in the sense that they're going to change your immune system.
like allergen immunotherapy.
Exactly.